going to get started. Dr. Koh.
Good morning. Welcome to the NCCN Patient Advocacy Summit, Best Practices and Policies for Addressing the Health Needs of LGBTQ+ cancer patients and survivors. So my name is Wui-Jin Koh, and I have the privilege of serving as CMO at NCCN. Dr. Carlson, our CEO, sends his regrets but best wishes. The virus finally outran him, but he is doing well, recovering well, and he's actually joining us online. So apparently I'm still supposed to behave myself. But I would like to thank all of you in person and the virtual attendees for participating in today's summit. So lesbian, gay, bisexual, transgender, queer, and a community of people face unique challenges in accessing health care, and the challenges in accessing cancer care are no exception. This community is at heightened risk for bias and discrimination. This bias and discrimination, including potential misgendering and lack of gender identity recognition, can lead LGBTQ+ patients to feel uncomfortable seeking out and continuing care. LGBTQ patients can be put at great risk for simply identifying as LGBTQ+, either by their healthcare team directly or through a breach of privacy to the patient's family and friends. This community can also face a number of challenges around transportation, employment, health insurance, denial of care, and lack of social support. Many providers lack education and awareness about how to best navigate LGBTQ+ issues, which then compound the problems themselves. It is critical for providers to understand the level and type of social support, including the chosen family that patients have. Previous NCCN events have explored these issues, but evolving research examining disparities in care access and outcomes now warrant closer examination by a diverse group of expert stakeholders, which we have assembled today. So today's summit will facilitate important and timely discussions of best practices and policies for addressing the unique health needs of LGBTQ+ identifying persons who are or will be impacted by cancer. We encourage all of you to engage with our speakers by submitting questions, whether you're here in person or participating virtually. We hope that you will consider engaging through your social media platforms using the hashtag NCCN policy. These topics are far too complex to fully address in one day, but we hope that the oncology community will continue these conversations by carrying them online and in person to those who are unable to attend. For those who are attending today's event here at the National Press Club, I would like to draw your attention to a couple of resources that are currently available today, the guidelines for patients, and these are available free. Copies are available today, but these are also available online. Near the registration table outside this room, you will find copies of the patient guidelines for adolescent and young adults and our newly completed guidelines for breast cancer screening and diagnosis. We hope that you and your friends and contacts will find these resources useful. Next slide. Oh. So NCCN gratefully acknowledges the many supporters of today's program. Without the support of these organizations, this summit would not be possible, and we really thank our sponsors for their generous support. Today's agenda is shown here. And it's a combination of keynote addresses, best practice presentations, and panel discussions. We welcome all of today's speakers and thank them for sharing their time and expertise. Our moderator for today is Dr. Clifford Goodman. Dr. Goodman is Senior Vice President of the Lewin Group, leading national healthcare and human services consulting firm. Dr. Goodman has over 30 years of experience working with government, industry, and nonprofit organizations in the US and abroad in areas such as health information assessment, comparative effectiveness research, clinical practice guidelines, and health economics. Those of you who've had the opportunity to participate in previous NCCN summits know well the wonderful attributes that Dr. Goodman brings to these meetings, and we look forward to his contribution. Now, I'm going to go off script. We usually make other thanks at the end, but today, just in case some of you are not here at the end, I would like to particularly point out Tennille Carter. Is she here? So Tennille Carter is the NCCN Manager for Cancer Care Equity, and she is, while it takes a village, she was the one who was uniquely in charge of putting this process together. And she also provided me the script so I don't go too far off. So at this time, it's a real pleasure to introduce our morning keynote speaker, Dr. Dora Hughes. Dr. Hughes serves as the Chief Medical Officer at the CMS Innovation Center at the Centers for Medicare and Medicaid Services. She leads the center's work on health equity, provides clinical leadership and input on payment models, serves as the Innovation Center primary liaison with medical and clinician stakeholders, and provides leadership to CMMI's clinician community. In addition, Dr. Hughes is part of the Innovation Center's senior leadership team, helping to provide enterprise-level leadership and strategic direction. Previous to this, Dr. Hughes served as Associate Research Professor of Health Policy and Management at the Milken Institute School of Public Health at the George Washington University, where her work focused on the intersection of clinical and community health, health equity, social determinants of health, healthcare quality, and workforce issues. Previous to this, she was a senior policy advisor at Sydney Austin, where she advised on regulatory and legislative matters in the life sciences industry. She's also previously served as the counselor for science and public health to Secretary Kathleen Sibelius at the U.S. Department of Health Services. In this role, she helped implement the Affordable Care Act and provided oversight and guidance to the Public Health Services Act and the Food and Drug Administration. Dr. Hughes received her Bachelor's of Science from Washington University, her medical degree from Vanderbilt, and a Master's of Public Health from Harvard. She completed her internal medicine residency at Brigham and Women's Hospital, Boston. We're so thrilled that Dr. Hughes has joined us this morning to share her knowledge and expertise on employing public health policy strategies for advancing equity through the CMS Innovation Center. Dr. Hughes, thank you.
Good morning. I want to start by thanking you for inviting me to join you today. I also want to echo thanks for Tennille, who certainly kept me organized and all the logistical prep and a little bit of whipping to make sure that everything was completed in a timely fashion, so I appreciate certainly all of that. This morning, I wanted to talk about our work at the CMS Innovation Center to advance health equity, which certainly, as you will hear throughout the presentation, will increasingly have greater focus on the LGBTQ plus community. I wanted to start with a story, because this is a story that was shared fairly recently with me. It was about, from one of our community partners, a hospital in Reading, Pennsylvania. And they shared the story of a single mother and a child. She had a 5-year-old son. And they routinely presented to the emergency department for non-emergent reasons. And on their 17th visit to the hospital, the 17th visit to the emergency department for this 5-year-old child, the family was screened for social needs as part of one of our CMMI models. They found that the family had all types of issues. Their heat had been turned off, they needed help with utilities. There were ongoing disputes with the landlord in terms of repairs and rent and whatnot. There was mold. They eventually discovered lead in pipes. It was all types of issues that needed to be addressed. And again, as part of the program, this family was referred to the social workers and other community partners who could help address these needs. Within a year, the family was no longer presenting to the emergency department. They were in a new housing situation. And importantly, by way of addressing these social needs, the mother herself was starting to participate in a smoking cessation program and taking care of her own healthcare needs once the more pressing social needs had been addressed. In addition to the quality, the experience of care, an interim evaluation has found that emergency department utilization has dropped by 9%. And so in terms of focusing on the quality, the outcomes, as well as cost, this is an example of the type of work that we think is very important, bridging the clinical and community health interventions that can address the needs of our beneficiaries in a more holistic fashion. The name of this model, the Accountable Health Communities, was our first foray into screening our beneficiaries and, again, helping to refer, helping them navigate the social services sector that could get their social service needs addressed in addition to their clinical needs. And this is done by systematically helping to foster partnerships between the clinical providers and the whole range of social service providers. When this was first contemplated in 2016, 2015, it was considered revolutionary that as clinical providers, particularly for CMS, the nation's premier health institution, would take this on. And now with the cultural shift and the transformation, we're able to see this is almost expected. And we're trying to think more about how do we facilitate this? How do we make it easier for the range of providers to work together to accomplish this? For those of you that are not as familiar with the CMS Innovation Center, we were created as part of the Affordable Care Act in 2010, and our statutory charge was to test models. We call them models, some might say demonstrations, research projects, we call them models, that can improve the quality of care and reduce the cost of care. Ideally both, but at least one of the other prongs have to be targeted by our models. And we have focused on a whole range of different settings, whether it's urban or rural, different populations, perhaps the pediatric, maternal, different provider types, the traditional physicians and nurses, but also ambulance providers as another example. And we look across all ranges of our insurance lines. That includes Medicare, both traditional Medicare, Medicare Advantage, but also Medicaid, Part D plans. I always joke a bit with my colleagues in Socio that Marketplace is next on our list. But we have been fairly expansive, we think, in our scope. In 1 2-year period, we tried to quantify our impact, and we found that we had touched over 28 million beneficiaries who were involved or touched by our models across all 50 states. We had over 500,000 providers or provider types that were participating in our models. And as you see here, we, again, are national in scope in our work. Certainly our models, it does depend in part on the population size because we have to have sufficient participation for our models for evaluation purposes. And so it's why we have to get the question was why so many in the Northeast or as an example. But population density is important, but we again are seeking to support models, transformative work across the nation and some of the territories. Now with regards to health equity, in 2020, at the end of our first 10 years, it was also the change in the administration, 2021. It made sense to take a step back and think about what have we learned in the first 10 years? What do we need to know to inform where we go in the next 10 years? And there's many lessons learned, but I've highlighted a few in red that I think have particular implications for equity. And the very first one, which is highly unfortunate, but we're very candid about it, is that we didn't actually always focus on equity. We didn't think about what impact our models are having on the range of beneficiary populations that we're serving, particularly those that are facing health inequities. We certainly also didn't have enough Medicaid models in our portfolio as well. When we think about the providers serving underserved populations, many of them were not able to participate in the models. They could not assume the risk, the downside risk, the penalties, for example. The success of models, too narrowly defined. Cost and quality, of course, are part of our statutory charge. But again, even if we think about equity, we should be able to quantify the impact that we're having as part of determining whether our models have been successful or not. And the last one, and I think is just, again, critically important, as fortunate as we have been to have an amazing cadre of partners in the clinical space, hospitals, providers, we didn't have the full range of partners that ideally we would have. For example, we had not fully engaged beneficiary groups, patient advocacy groups. We have certainly not even just hearing the direct patient voice in addition to the groups representing them. Those are examples, and certainly groups representing traditionally underserved populations were not, again, part of our inner circle in our first 10 years. And so with all of these different lessons learned and also the direction of the administration, we, a year ago, launched our 2030 vision statement, if you will, our guiding post for the next 10 years. A health system that achieves equitable outcomes through high quality, affordable, and person-centered care. And we have 5 pillars that are helping to guide our work. The first is accountable care. We want 100% of Medicare beneficiaries and the vast majority of Medicaid beneficiaries to be in relationships that are defined by accountability for quality of care and the total cost of care. Equity, which I'm going to dive a little bit deeper in the next slide. Driving innovation. What's the technology? What's the tools? What are the learning systems that can allow our participants to be successful in these value-based care arrangements? The fourth pillar, addressing affordability. Traditionally, we focus on what are the costs, costs to the healthcare system broadly, but we're also increasingly thinking about how do we reduce costs for our beneficiaries, for their pocketbook, for their wallet, particularly in the advent of the Inflation Reduction Act and our own executive order. Affordability certainly is rising in prominence. And the fifth area, as I touched on, we need to have better partnerships with other groups outside of our traditional sphere of focus. So in terms of advancing health equity, we have defined, and we're going to continue with 4 areas of focus. The first, as we think about models, particularly new models, but also models that have at least 3 years left in their lifespan, how do we make sure that equity is embedded throughout? Even as we think about the model concepts, does it have relevance for underserved populations? What are the care delivery requirements and the guidelines that we expect for our participants? What are the financial mechanisms? Not only just how the structure of the financial payments, but also the level of payments. Are we getting that part right? How do we think about risk adjustment, including social risk adjustment? So all of that certainly is critically important for us, and just even starting down this health equity path. The second is when we took a look back, we found that most of the beneficiaries served in our models were white and affluent. And so how do we make sure we're serving the full diversity of our beneficiary populations, particularly populations of color, lower income populations, those in rural areas? We think key to that strategy, key to that, is making sure we have safety net providers included in our models, including FQHCs or rural health clinics and others. And so that is certainly part of our strategy, including more Medicaid providers. The third area always seems a little ho-hum, but again, since we had not evaluated our models for the health equity impact, We want to be very deliberate in designing our models with the evaluation in mind. So we're asking the right questions, collecting the right data. So at the end of the 5 or 8 years or whatever the lifespan, we'll know the impact. And the final area is just critically important, and I think is the linchpin to our success across all of, certainly these areas of focus, and frankly across all of the pillars. And that really we need to strengthen our data collection and intersectional analyses. We have some race and ethnicity data. That's probably the best that we have in terms of for underserved populations, even though that's quite flawed. But then it falls down pretty dramatically if we think about populations defined by sexual orientation, gender identity, certainly defined people with disabilities. Our data is just sorely lacking. And so we're trying to think about, through our work, how can we collect data that we need to, again, understand how our models are working or not working, and what improvements need to be made, what success that we've had. And we're thinking both internally for our models, but we're also looking across the centers at CMS, and I use analogies, but what can we beg, steal, or borrow? Or even outside of CMS, thinking about some of our other agencies at HHS, and even outside of HHS in terms of acquiring better data for, again, the range of populations that we're serving. I won't dwell on this. Again, I just want to emphasize the point that we're trying to think about this from soup to nuts. Again, when we start to think about models, recruitment and rulemaking, who are we talking to when we're thinking about a model? Who are we getting input in early on? Who are we reaching out to say we hope you participate in our models? What assistance are needed for the applications to get through the application process? What are the criteria? We want to signal that we value experience and expertise in caring for underserved populations. And evaluation and scalability, sustainability, also all very critically important. So then just to go through a few model initiatives and highlights. We just launched in July of this year an Enhancing Oncology model. Very excited about that. There's a number of health equity components specifically. Our participants will be required to collect and report to us sociodemographic data. We also have additional payments for providers in a number of different ways, whether that's the risk adjustment benchmark, increased per member per month payments, the monthly enhanced oncology services payment, I think the MEOs, for those that are familiar, that again, for our providers that are taking care of disproportionate number of underserved populations, we know that they will need additional resources. And we are testing that as part of our model, the structure of the payments, the level of payments. Screening for health-related social needs will be required. Every participant will be required to submit to us a health equity plan. We want them to make sure that they know all of the needs of the beneficiaries, the populations they're serving. Are there any disparities for any groups? How do you intend to close any gaps in care and outcomes, all of that. So this model will formally launch in July of next year, but additional information will be coming out certainly early next year that will provide more information on many of these components. I think for our Part D, for our Medicare Advantage Value-Based Insurance Design Model, or VBID, for many of you may know, a few years back, the Congress provided special new authorities for the MA plans that they could target beneficiaries if they had chronic illnesses and provide them additional services and benefits. Building upon that, now we're able to target beneficiaries and through this model for those that are considered underserved. And we're testing that. Like, what happens if you provide food assistance or transportation? If we think about, again, their needs more holistically and are able to address not only their clinical needs, but their social needs. And we think that's particularly important for the MA population. Outside of our models, we don't have good information about what these additional benefits are. But within our model, we can request what actually special benefits are you providing? What has been the impact on care? It's always a lot of the evidence base is growing in this field, and we think that we'll be able to add to it with our model. In terms of ACO REACH, again, this one was announced in March of this year. This will launch in January. It too has a robust equity provisions as part of it. They will also have to collect socio-demographic data. The benchmark is adjusted in terms of so that more resources will be provided to those caring for a disproportionate number of beneficiaries. In this case, those that are dually eligible for Medicare and Medicaid, and beneficiaries living in deprived areas as measured by the Area Deprivation Index. They too will have to submit a health equity plan. We were quite cheered for the participants in this model. They were invited to submit a health equity plan on a voluntary basis, and a surprising number of our participants did submit the plans, and they were much more advanced than we had expected. So we are quite encouraged to see the enthusiasm and the level of expertise coming in for the ACO REACH model that we think will have an impact. And data collection, as always, I cannot emphasize that enough. Primary care first, I think particularly relevant, certainly in the cancer context. We know that the bulk of preventive services, screenings will come through primary care settings. This is our third primary care model, and we've certainly signaled that we are working on our fourth model that's all focused on providing comprehensive primary care services. And I think I put these slides in, I just think it also shows that even as we are thinking about new models that are underway, we're working on developing models, we're already trying to look at early data indicators to find out how are we doing even for the earliest years of the model, so that we're not waiting to the end of the 5 years. And I think this graph is a good one. If you look at the open dots where the circles are, those are where our participants, our primary care providers, are located in the Los Angeles area. But if you look in the maroon dots, that's where most of the Latinx communities are in the Los Angeles area. So you can see that there's an imbalance between where our participants are located and where, in this case, the Latinx and lower income communities are in Los Angeles. So the questions for us, what is it about our models that appear to potentially disincentivize participants from working in these underserved areas? It could be there's not enough Medicare providers in these areas, or maybe there's not enough Medicare beneficiaries in these areas. It could be a whole host of reasons, but at the outset, we need to understand why. We need to learn more about what's happening. And so I think for many, we're like, well, perhaps Los Angeles was the outlier. We found the same situation in Detroit, where again, most of our model participants in our primary care models were not serving patients in the pink areas where most of the African-American residents, the African-American communities in Detroit are located. So even just knowing right from the start that we have this imbalance, and as we're working on our next primary care model, and the importance of primary care, particularly as a foundation of our healthcare system, where the early services, the preventing screenings, the behavioral services, all of that needs to be, again, fully distributed across all of the beneficiary populations that we serve. We're trying to be more formal about that. In July of this year, we published our findings from a pilot project looking at implicit bias for 3 of our models. And that we did find, because of the potential for bias, we may have inadvertently restricted eligibility for certain groups in our models. Based on our pilot, we're trying to develop a toolkit, a more rigorous process from looking at our models earlier to see if there is a potential for bias and thinking about what steps that we may need to take to address that type of bias. And I would be remiss if I didn't point out that and just about 3 weeks ago, I believe, within the month, we released our 1-year look back. What did we accomplish in the first year? What successes did we have? And very importantly, what are some of the metrics that we might use to track our performance over the next 10 years? As part of our strategy refresh last year, we just released, this is our new vision, this is what we'd like to do. This year, in addition to the look back, here are the metrics that we're going to judge our performance. And some of these, again, focusing on how much data are we bringing in, again, across all of the various underserved groups that we care for. thinking about how many safety net providers and facilities, and then actually looking at some clinical measures as well. All of these, we think we have good baseline data, and we will hold ourselves accountable to the goals that we set out as part of our vision. I also think due at CMS Innovation Center, we were in many ways first out the gate in terms of our health equity plan, but there is a broader CMS health equity plan that was released a little bit later that represents all of our centers, Medicare, Medicaid, the marketplaces, everyone's interests and intentions. And I think it's really clear, one of the points that our administrator, Chiquita Brooks-LaSure, likes to point on, again, we're focusing on populations defined by race and ethnicity, but we are trying to move as rapidly as possible, notwithstanding the data limitations, to think about, again, the other populations that could be defined as part of the underserved population, as she lays out here, those defined by sexual orientation, gender identity, disabilities, as I mentioned, those in certain geographic areas, preferred language, all of that we are trying to really think through across all of our colleagues and with colleagues at HHS, and particularly the Office of National Coordinator. When we think about data, we peg our requirements to the US Core Data Interoperability Standards version 2, and it will certainly version 3 as soon as it's available, the voluntary standards there. So sorry to dive a little bit wonky, but I think it's important to point out that we are not working in a silo here. Scaling sustainability, I think we found that for many of our lessons learned that there wasn't the level of adoption nationally as we would have hoped, whether it's our diabetes prevention program or maternity programs. And so just, again, trying to be mindful in terms of thinking about sustainability from the earliest stages. And I also talked about the executive order that was released on October 15th that's focusing on lowering drug costs for individuals. We will be releasing in early next year our proposals for models that will address drug costs. And I'm very pleased to say that as our criteria for what models we might use to test efforts to lower drug costs, equity was one of the criteria, not only just in terms of diseases and conditions, but how will it impact our lower income beneficiaries as an example. So we're pretty excited about the potential efforts in this space. Certainly, whatever we propose will be complementary to our colleagues in Medicare who are leading implementation of the IRA. I always have to give a minor shout out. We were quite pleased that one of our models was picked up as part of the Inflation Reduction Act and codified into law. We had an insulin model where, given the rising costs, some might say the soaring cost of insulin over the past years, we had a model that provided insulin at a capped amount, $35 per month per insulin product. It was very popular among beneficiaries. And so even without the model concluding, the Congress picked it up and codified it into law so that all beneficiaries would have access to this capped lower cost insulin product. So we think that that's an excellent sign of the type of transformative work that we're having, the shifts that we're seeing, and certainly for equity considerations. This model too had more representation from higher income white beneficiaries, and so we also think is a marker for us that we have to, again, think about how we're making sure that all of our beneficiary populations are benefiting. And our final note, for all of you, if you're not participating in the Healthcare Payment Learning and Action Network, the LAN, I would encourage you to do so. There is a Health Equity Advisory Team, very ably led by Dr. Marshall Chen and Karen Dell. They have been focused on helping think through for our commercial partners, public partners, how value-based care arrangements, what are the critical elements of value-based care? What are the critical elements for our alternative payment models that will particularly benefit our populations, again, that we would describe as underserved? And so some of their work, I think, would be publications, I think, would be quite helpful for all of you here. So with that, I always like to refer back to this quote again from our administrator when she was confirmed. She said, "Our agenda is ambitious, but the times call for bold action." And I think I could speak on behalf of all of my colleagues at the CMS Innovation Center to say that we are very much committed to the bold actions that will allow us to achieve our vision, again, of a health system that is achieving equitable outcomes through high quality, affordable, and patient-centered care. So with that, I thank you. There's other resources on the website. And of course, there's my email. Be happy, certainly feel free to email me directly, and I can help. If I can't answer your question myself, I'd be happy to link you with the appropriate team. So with that, thank you so much.
Well, thank you very much, Dr. Hughes. As always, we have a couple of mics, a couple of our wonderful mic runners. If you have a question, please kind of raise your hand and someone will hustle over to you with a microphone. While we're waiting for that, Dr. Hughes, just a couple kind of lead-in questions. First of all, that was a rather persuasive set of maps for underservice in Los Angeles and Detroit. I mean, those pictures told more than 1,000 words. Right. In line with that, with regard to these disconnects, Dr. Hughes, when you consider the LGBTQ+ community versus broader sets of underserved communities, can you tell us a little bit about kind of the Venn diagram? To what extent is there some overlap with regard to the full set of underserved communities and the LGBTQ+ communities themselves?
Yeah, that's such an important question. And in part where we seem to be perhaps a little too focused on the data, our data is deplorable in terms of identifying our beneficiaries who by sexual orientation and gender identity. It's just a major gap. And so it's one of the areas that we're specifically focused on, and requirements through our models that this is being clear that we expect our information on our beneficiaries to be shared with us. And so not only just in terms of thinking about the mismatch, but our evaluation, what are the lessons learned? Are they getting the proper care in accordance to recommended guidelines? And so that is one of the issues there. And I'm pleased that it's not just the CMS Innovation Center. Our colleagues in the CMS Office of Minority Health are really corralling, helping to convene all the different data leads across CMS to help think through. And we're also working with our colleagues in the Department of Health and Human Services on, again, having better data for these. But that being said, I like another colleague always says we can't wait for the data to start to act, right? And so even just thinking through, looking at who's coming in. We know there are, if we just think locally here or others, there's health centers that we want to reach out to say, would you consider applying for our models? We know that certain conditions are more likely to be prevalent. Are we focusing on that in our model? If we think about the clinical guidelines and screening, and what's the level of awareness about the disparities that we have to be mindful of, and for different groups. So obviously we can't conflate what's for the various different groups and issues. So I think I'm like to be very candid that we have so much work to do in this space, but I do think that there is the right level of attention and commitment to doing more.
Thank you. And again, we have mics running available if you've got a question. I see a question here, please. This will be the first, and then I see one second here. So we've got two ready. And could you give your name and affiliation, please?
Lisa Pyle. I'm a pediatric geneticist at Children's National here in DC. This is a rather pointed question, actually. My specialty is in cancer predisposition for folks with intersex and DSD variations. And one of the things that I'm noticing is, the NIH definition is sex and gender minorities. I notice we're talking about sexual orientation and gender identity. We're not necessarily talking about sex minorities, given that cancer predisposition issues is one of the biggest areas that community is trying to advocate around. Who do we go to start fixing that?
In terms of fixing which part? There's many issues that you mentioned just right there.
Good question. Good question. In making sure that we're including the I in the LGBTQI plus,
Yeah.
because cancer predisposition and cancer is a major. I mean, it's focusing on that for that population is my entire career. It's a major issue, and it keeps a lot of us very busy.
Okay.
Yeah, I think I would, I mean, first, you'd be welcome to email me and I could directly link you. For us, in terms of how we define and we do certainly refer back to the executive order that the president released, and then the CMS definition of health equity, how the terms and defined or descriptors are very much aligned with how it's been defined by the administration. But I think that was over a year ago at this point, and I just think that some of the discussions and the deliberations, frankly, within the Department of Health and Human Services are already kind of signaling that we need to be more expansive. So I think you would find a receptive audience. How much leeway we have to make changes, that I don't know, but I think you are on point, particularly in the context of the efforts to increase, improve the data that we have. I think that it would resonate with a number of colleagues.
Good, thank you. Our next question, please, name and affiliation, please.
My name is, there we go, Scout. I'm the Executive Director of the National LGBT Cancer Network. First of all, I want to say thank you. Actually, CMS is the first optive I've ever seen where I see the director coming onto calls and introducing herself with her pronouns. So that's amazing, one good start. And second of all, we know that there's actually been a lot of precedent set related to data, and by that, not regulatory, but leadership precedent, which encourages places like many of the organizations here to follow, with the Joint Commission doing their new toolkit related to SOGI data collection, also with the HEDIS proposed standards that LGBT potentially be part of it, and also with NCI giving $150,000 supplements to, we don't know exactly how many NCI designated cancer centers, it might be 20 even out of the 66, to collect data. It's starting to create a huge shift. And so what I'm wondering is, does CMS and the Center for Innovation have options like that where you might be able to create toolkits, you might be able to do potential supplemental funding, because we're really seeing it's changing the way the health-serving agencies are responding. They really are very reactive to understanding that this is the next generation, especially cancer centers. No one wants to be behind the curve related to this.
Mm-hmm. That's a very good point. In terms of funding, that's always very difficult just by our statutory requirements. The funding we release has to be tied to an actual model test. And so we don't have the same flexibility. We're always very jealous of our colleagues and some of the other agencies. But that being said, you do raise a good point. And that's, we do have a group within that is focusing on learning systems, and they provide webinars and toolkits and roundtables. And I appreciate your point that we should be sharpening our message and expectations in ways that could signal a shift towards collecting better data, thinking more carefully about, again, the populations you're serving, what are the guidelines. And the guidelines, that's another interesting issue, even for our newest oncology model. We set out the requirements that there's expectations you adhere with recommended guidelines and so on and so forth. But I'm not even sure in terms of the information that we're requiring back, that how granular we're getting, and could that be another possible option for us to, again, to highlight kind of our interest in these areas and commitment to the issue. So thank you for that. I appreciate that, that idea. And our colleagues in the CMS Office of Minority Health have just been a tremendous resource in thinking about equity broadly, and tend to be our partners, and so I'll certainly share with them. I have no doubt they're probably far ahead of us on many of these issues, but I'll take that back.
Good, thank you. We've got time for one brief question, just 1 minute left, really. Yes, it is.
We have an online attendee asking how healthcare advocacy groups can get involved with the Innovation Center and how they can be involved with informing the models.
I love it. That's a perfect note to end on. We recently, by way of my colleagues in the Learning and Diffusion Group, LDG, released, they have developed a beneficiary engagement strategy and how to be more systematic in reaching out to groups instead of waiting till groups to come to us, but how do we reach out and make sure we're bringing all the different voices to the table. That being said, though, I think I would encourage, I promise you, we hear from every manufacturer, every diagnostic, I mean, we hear from a lot of people in the clinical space. I find that we don't hear as much for those outside of the traditional clinical space, and in many cases, those are the voices that we most especially need, and very frankly would love to do a better job partnering with. And so to the extent reach out, you can reach out to me. I would be happy to link you to the right individuals. It's quite a team.
Well, with that, Dr. Hughes, thank you very, very much. We know that there's a lot cooking over at CMMI and the administration in general. It's wonderful to have you carve out the time for us. And we warned you, we'll get pointed questions here at the National Press Club from NCCN, and you're up to it.
We need the pointed questions. I appreciate them. That's excellent input and feedback for us, and we value that. So thank you.
Thank you all. Thank you very much. Thank you, Dr. Hughes. Okay, so programming note, we're going to take a 10-minute break now. It's probably closer to 8 minutes. When you come back, a couple things to keep in mind. When you come back, Dr. Koh, whom you've met, is going to introduce the Assistant Secretary for Health, Admiral Levine, who will give us a 10-minute video. During our break, I respectfully request that our panelists for panel 1 on breaking barriers go to the back of the room to get mic'd up, and please be seated while Admiral Levine is offering her remarks. So we'll all be ready to go. All right, see you at 10:20 Eastern. Thanks, everybody. Good start.